The topic are big topic. I'm going to try to simplify as much as I can. No, contents they are to a background now the during pregnancy cardiovascular system physiological changes and now to the antenatally, prenatally, antenatally, intrapartum, postpartum management and general principle a little bit on some high-risk conditions and some medications used in cardiac patients with effects on pregnancy. And the last one is the key points. So, so what is the background and scope of the problem? So there is an increasing prevalence of cardiovascular disease in pregnancy. Yeah. So there are two important things here. So there is increasing prevalence of cardiovascular system disease in pregnancy. And the second important fact is it is a major cause of indirect causes of maternal death. Yeah. So cardiovascular diseases congenital heart disease acquired heart disease congenital heart disease it constitutes 0.4 to 1% of general population Western world solution non-hypertensive cardiac disorders majority 75 to 82% due to congenital heart disease during pregnancy no so the surgical treatments they are improved advanced surgical treatment advanced early diagnosis even in utero diagnosis the neonatal treatment and also other improved surgical treatment through survive to adulthood they are not cured. Yeah, so they're not cured. So it is very prone to high risk of cardiovascular complications, premature death. The pregnancy-related deaths, congenital heart disease, acquired heart disease, relatively still low incidence. The acquired heart disease, sometimes, most of the time during pregnancy, after 20 weeks, mama, through our first time in a presentation at the time of delivery, immediately after delivery, so cardiac events in cardiac events they are myocardial infarct, ischemic, sorry, arrhythmia, aortic dissection, so throughout the diagnosis late period acquired heart disease it is become the one of the major cause of maternal mortality. Now the check the good trends are the maternal age getting older. So the trend is towards having children later in life. The higher rates of cardiovascular risk factors accompanied such as hypertension, diabetes, so on. Yeah, so the acquired heart disease solution non-Western world solution solution level still rheumatic valvular disease still very common to our solution the majority of the cardiovascular diseases do comprise so up to 90% of congenital up to 90% of cardiovascular diseases are acquired heart disease the maternal mortality solution this is the trend starting from 2004 up to 2018 mortality are reducing trend the line combination of direct and indirect maternal death rate. So it is the rate per 100,000 maternities. And when you look at indirect cause of maternal death, so indirect cause is always greater than direct maternal death. So the direct maternal death solution, the Patma Vaima, များပြီးတဲ့ခါကျတော့နောက်ပိုင်းကိုနည်းသွားတယ်အဲ့ဒါဘာဖြစ်လို့လဲလို့ဆိုတဲ့ခါကျတော့ဒီ around the time of 2008 2009လောက်မှာဒီ thromboembolism တို့နော်ဒီ hemorrhage တို့ပေါ်မှာ preeclampsia တို့ပေါ်မှာဒီ concentrate လုပ်လိုက်တဲ့ခါကျတော့ဒီသူတို့ကြောင့်မလို့ဖြစ်လာတဲ့ cause of death တွေကတော်တော်ကြီး significantly reduce ဖြစ်သွားတယ်နော်ဒီ whereas indirect maternal death ကတော့ there is no significant reduction. So this is the latest statistics for 2017-2019 maternal mortality. So in which you will see that cardiac disease is the commonest cause of maternal mortality. That is 1.6 per 100,000. Yeah, and neurological is second. Thrombosis and thromboembolism is fourth cause. Yeah, and preeclampsia is quite nearly towards the end now because we're now very good at managing preeclampsia. So when you really look at the particular condition of the cardiovascular disease solution, the ischemic heart disease solution constant no, the maternal mortality due to ischemic heart disease solution persistent which is the light blue color, yeah, and deaths due to congenital heart disease reducing trend so because of the reasons I've mentioned already, whereas other acquired causes the trend is increasing. The acquired cardiac conditions common sudden cardiac death syndrome, so which is related to the cardiac arrhythmias, peripartum cardiomyopathy, aortic dissection, myocardial infarct, and rheumatic mitral stenosis. These are the most important causes of maternal mortality due to cardiac diseases. So pregnancy increasing demands for anatomical changes as well as physiological changes to supply the needs. Yeah, anatomical changes during pregnancy, uterus becoming enlarged, and then there is elevation of diaphragm. So as a result, heart the long axis rotation towards the left and upward direction. Sorry. And as a result, there is a electrical axis shift to the left. Yeah, so we call it left axis deviation. So this is a physiological changes during pregnancy, during delivery and after delivery. Yeah. So when you look at that graph solution, so total peripheral resistance gradually reduced. So to a cardiac output stroke volume and heart rate significantly increased accordingly with gestation. Stable systolic blood pressure. Systolic blood pressure second trimester a little bit reduced slightly increased later towards the term. Whereas cardiac output, stroke volume, and heart rate start to increase from around second trimester, and still gradually increasing until term. And during contractions in delivery solution, at the peak of contraction do a further increased in volumes, yeah, but it comes down between contraction, and then after delivery solution underlying cardiac diseases second trimester towards the end of pregnancy, and also during delivery and immediately postpartum. Yeah, so stroke volume stroke volume the peripartum period around the time of delivery the chain towards the ends of the pregnancy, during delivery, immediately after delivery, any periods there solution the chain, very important times during which cardiac events are commonly developing. So total peripheral resistance are to accommodate the increase in cardiac output and stroke volume and plasma volume. Okay. Okay. And as a result, the normal pregnancy the physiological changes, the cardiac disease symptoms overlapping diagnosis late. So it can lead to the late diagnosis. So some of the examples of the symptoms which is present in the normal pregnancy are on the left side, so fatigue, exertional dyspnea, palpitation, sometimes atopic beats, sinus tachycardia, but it's not that very high, only 10 to 15% above the normal heart rate, full volume pulse, that heart sound, you may hear that heart sound, and systolic flow murmur, and also it is common to get pedal edema and ECG. Some changes in ECG due to left axis deviation, so such as small Q wave, inverted D wave, especially in lead 3. Yeah? So signs and symptoms that suggest cardiac pathology are chest pain, severe breathlessness, and unique symptom of cardiac disease during pregnancy are atopnia, paroxysmal nocturnal dyspnea, and cough. So it is the unique feature of cardiac disease in pregnancy. We should never ignore that symptoms. Okay. And sinus tachycardia. So sinus tachycardia more than 15% above normal heart rate. And when you hear the fourth heart sound, and pulmonary edema, pleural effusion, and rhythm abnormalities. Yeah, so such as atrial fibrillation, atrial flutter, ventricular tachycardia. So, DAR or Balelo solution. What are the very high risk? Who are the very high maternal? Who are the pregnant ladies with very high maternal risk that can lead to the catastrophic complications? And who are the women with high maternal risk, which is manageable? Okay, so catastrophic risk pregnant women solution. The left-sided stenosis lesions. So left-sided stenosis lesions, they are solution. Severe aortic stenosis, mitral stenosis. So as a result of that, the ventricle contraction so measure ventricular ejection fraction less than 30%. Yeah. So, and poor functional class. So there is a classification called New York Heart Association to assessment of the stage of the cardiac failure. Yeah, so if it is stage 3 and 4 solution, they are very high maternal risk. It also depends on the aortic diameters. Yeah, so in some conditions, aortic diameters is increased. For example, Marfan syndrome, bicuspid aortic valve tumor. Some conditions, are very narrowing, severely narrowed coarctation of aorta. Okay, and pulmonary arterial hypertension, and someone who had previous cardiac event or arrhythmias. The pregnant women is solution. To be honest, solution, they should be discouraged to get pregnant. The pregnancy are very dangerous, harmful period. Through warning on the right side, pregnancy with cardiac conditions, which can lead to manageable risk during pregnancy. Mechanical heart valve prosthesis, and some of the congenital abnormalities which are repaired, such as systemic right ventricle, univentricular heart. Yeah. Marfan syndrome, aortic diameter, they grow mature. Mitral valve stenosis, yeah, but more than 1.5 square centimeter, and systemic ventricular ejection fraction more than 30%. Yeah. So, sorry, that is. So what about the baby? Yeah. So there are also fetal risk as a result of the maternal hemodynamic changes due to cardiac diseases. Yeah. So there are three main risks here. So first, miscarriage, prematurity, low birth weight babies, small for gestational age babies, growth restriction. Mainly the maternal hemodynamic conditions for mamutire. So the left-sided obstruction and very severe left ventricular output very low hemodynamically the blood supply to the baby are reduced with the complications. Now, on the other hand, the cardiac diseases are genetic conditions. Genetic conditions the mother genetic conditions the conditions there is 50% chance of getting the pregnancy with the same condition. Example, so Noonan syndrome pulmonary stenosis. Now, the Marfan syndrome, the Marfan syndrome aortic dilatation. Every pregnant women are conceive. Every pregnant women their children have 50% chance of having the same condition here. Now to the genetic condition the cardiac diseases claim a 3 to 5% chance of recurrence here. Risk factors for neonatal events. In addition to the underlying cardiac condition, the mother and the smoking, use of anticoagulants, multiple gestation, mechanical heart valve, and maternal pre-pregnancy function and class 2 or cyanosis. Conditions fetal risk, pure miscarriage, prematurity, low birth weight, common payment. The prenatal management, the general principle of your solution, prenatal management, prenatal management of how so preconception before pregnancy, the management for cardiac cases. Medical risk assessment. The two case number 2 surgical treatment consider Upama solution, severe mitral stenosis, aortic stenosis solution, interventions since now to go to pregnancy very, very high risk period the male health education behavior. In fact, you can discourage pregnancy. And number 4, healthy lifestyle encourage such as healthy diet, exercise, reduce weight, stop smoking, etc., and avoid fertility treatment. So assisted reproduction, assisted reproduction underlying cardiac disease medications hyperstimulation hyperstimulation of the ovaries and reproductive systems. As a result, the cardiovascular changes for example solution the capillary permeability increase the fluid collection at the extracellular space underlying health underlying cardiac condition solution exaggerate the fertility specialist they should be considered. They should consider that complication. And the last thing are genetic counseling. Yeah, so genetic counseling cardiac disease the genetic condition associated solution, and what is the chance of having the same condition in the baby? Prenatal management. The risk assessment risk assessment 4 stages. Risk stratification. Risk ko stratify the risk factors so women with cardiac heart disease you can classify into cardiac risk factors obstetric risk factors the underlying the type of cardiovascular disease now to risk modifiers fetal risk the cardiac condition underlying cardiac condition cardiac risk factors age, ethnicity, parity, obesity, smoking, and other comorbidities such as hypertension to access to specialist care. Now to patient obstetric risk factors the anemia, preeclampsia, venous thromboembolism. Now to the risk modifiers are to my previous medical history arrhythmias heart failure stroke to transient ischemic attack to now to about treatment to so anti-arrhythmic treatment prophylactic intervention now fetal risk now to are you all right? So myocardial function valvular function the echocardiograph assessment now to the exercise capacity resting ambulatory okay. Step 2 risk assessment the risk to stratify maternal risk risk manageable catastrophic catastrophic death, stroke, irreversible heart failure manageable risk transient functional deterioration arrhythmias transient heart failure, bleeding, thromboembolism assessment now to fetal risk solution is there any risk of small for gestational age, prematurity, recurrent risk? Is there any teratogenicity as a result of cardiac medication? And also you should consider as well the impact of pregnancy on the long-term outcome of congenital heart disease. Risk stratification, risk assessment women pregnant patient discussion with cardiologist physician understand women in the risk long-term risk pregnancy potential impact recurrent risk physician familiar values cultural values decision decision informed decision management planning the manageable risk to continue to embark on pregnancy solution obstetric precautions vaccinations updated medications being follow-up plan during pregnancy how frequently should she be seen soအဲ့ဒါတွေအကုန်လုံးကို planning လုပ်ရမယ်နော်နောက်တစ်ခုကတကယ်လို့ဟုတ်လားဒီ catastrophic ဖြစ်နိုင်တယ်ဆိုလို့ရှိရင်if women decided not to continue pregnancy based on the informed decision solution, you should offer access to appropriate contraception or give the information regarding safe termination of undesired pregnancy, or you can also give the information about adoption surrogate pregnancy. The part karabale patient education, patient education is very important. Yeah. So this is antenatal management. Yeah. So antenatal management risk assessment 4 stages ko log de no log bi kha ja ro the clear plan for delivery in puerperium, and then it is not only for yourself, it's also for the patient and also the whole team. Yeah, must know your plan. Okay, the risk assessment and management plan are well documented in the patient's notes and widely distributed to the teams. Yeah. The women can go into labor at any time, so everybody needs to know what to do when she comes in labor. Okay, and number 2 monitor. Yeah, so monitor the signs of deterioration, monitor the signs of additional load, monitor the signs of venous thromboembolism. Yeah, so under Dimaro, venous thromboembolism are still the leading cause of maternal mortality. So every time the women come to hospital, we assess is there any risk of venous thromboembolism, and then depending on the risk, we offer the intervention. We offer either conservative interventions or injectable blood thinning agents. Yeah. The additional loads they are anemia, hypertension, gestational diabetes, deterioration vital signs regular ECG, echo, event MRI, yeah, is not contraindicated during pregnancy, and then event if it is necessary, you may do CT scan, right? Also, you may assess the patient does need interventional procedure or not, such as in case of mitral stenosis and aortic stenosis solution. For example, balloon valvoplasty, the STEMI, the ST elevation myocardial infarct, infarcutaneous therapy, the arrhythmias solution level, pacemakers, ICDs insertion open heart surgery or during pregnancy fetal mortality are very high cardiopulmonary bypass solution level within around 28 weeks gestation also delivery at the time of the surgery. So fetal assessment during pregnancy solution, routine ultrasound. Routine ultrasound at 12 weeks 18 to 20 plus 6 weeks 12 weeks if it is good ultrasound machine solution, you can diagnose the major cardiac problems. Yeah, and if there is specific indication solution, fetal echocardiogram for example. So if the mother is taking some medication that is causing that can cause the cardiac abnormalities during pregnancy, such as anti-epileptics, type 1 diabetic mother, prenatal diagnosis. Prenatal diagnosis genetic condition related solution. You can offer the invasive test in order to diagnose the baby having the same problem or not. The invasive testing, non-invasive testing. It doesn't need to do invasive test. Non-invasive prenatal diagnostic test you offer low 9. the advantage knowing that it is not only for termination, it's also for preparation for the pregnancy. Yeah, so if you know that your baby is possessing such kind of conditions, you can prepare yourself, and also the arrangement where to deliver the baby, when to deliver the baby, in which or sometimes the baby need to be delivered in the hospital where neonatal facilities are available, right? Now to call intrapartum. Intrapartum management in the aims are 3 aims here. So to stabilize the cardiovascular system, to monitor for deterioration, and to minimize any additional load. Okay, so bio monitor solution, blood pressure, pulse rate, respiratory rate. Respiratory rate is very important, very important, and we always forget to remember respiratory rate monitoring. And oxygen saturation, very important, yeah, because they give the very vital clue what is happening in mother, yeah. And fluid intake output, very important. And sometimes you may need continuous ECG, pulse oximetry, and some invasive monitoring such as intra-arterial pressure, central venous pressure. Okay. Also, some cardiac cases, well, so sometimes we consider induction of labor at 40 weeks. Reasons are sometimes the patient is taking anticoagulants. Yeah? So anticoagulants utilization, it is a very tricky situation. So depending on what type of anticoagulant, around the time of delivery solution, the timely season induction to prevent hemorrhage, to prevent risk to the baby. Now to induction of the solution. So we choose a specific time where everyone is on board, where everyone is available, yeah, at a safe time, safe place. So for example, solution, instead of inducing labor at Friday, yeah, so Friday afternoon, we will try to induce labor on Monday so that she can be delivered during the week time, good timing, where everyone is available, okay? And so the mode of delivery are vagina delivery, no? Vagina delivery with adequate pain relief are main aim, no? The obstetric indications here, so Cesarean section. Now, in particular solutions, some cardiac conditions which need Cesarean section are pulmonary hypertension, aortic dilatation more than 45 millimeter, coarctation of aorta. So aortic dilatation more than 45 millimeter, coarctation of aorta, Cesarean section low. So second stage, push low line solution, dissectionဖြစ်သွားမှာပေါ့နော်အဲအကြောင်းလိုအပ်တယ်နောက်တစ်ခုက severe aortic stenosis အဲ့ဒါဘာတွေ့လဲလို့ဆိုလို့ရှိရင် to prevent pulmonary hypertension နော် heart failure အတွက်နောက်တစ်ခုကတကယ်လို့ pregnant women who is taking oral anticoagulants if she goes into labor prematurely solution level Cesarean sectionလိုအပ်တယ်again, so vaginal delivery solution, there is risk of fetal hemorrhage. Yeah, and if the patient is suffering from heart failure, yeah, solution, the cardiac GA, cardiac GA is cardiac theatre lower me no. That stage postpartum management. Now the postpartum management in uterotonics the area so the first line in oxytocin method so oxytocin method now oxytocin go below solution concentrated regime fluid 50 ml normal saline 50 ml 40 units oxytocin given over 4 hours. So the idea bilateral solution fluid overload to me Now to kuajaro, misoprostol and carboprost. Misoprostol and carboprost, these are the prostaglandins stable, no? Prostaglandins they are the misoprostol, especially misoprostol carboprost, the second line. But need to be very careful when you are using these two. No? And algametrin avoid you must avoid because there is a risk of hypertension and also risk of coronary spasm. Yeah. And high-level surveillance, even after delivery, some patients they need longer stay in hospital. And they should have recheck echo before going home, and also need follow-up in the puparium. Okay, so others you need to assess the venous thromboembolism risk, and some cases might need stopping breastfeeding, and also need to educate about the contraception. Yeah, so she should not pregnant again within a year time. Okay. So there are specific conditions. Specific conditions. Salient points later. Myocardial infarct, acute coronary syndrome. The prevalence are increasing. Older age. Yeah. So pregnant women are older age. Now the child risk factors they are obesity, hypertension, smoking, diabetes, pre-existing hypertension. The package of older age. So cardiovascular risk factors the prevalence are increasing. Now the sometimes solution diagnosis can mispitted. So low threshold for diagnosis could harm chest pain solution. The BNP not anti-pro BNP solution. Very high predictive value to detect cardiac events later in pregnancy. If it is done at 20 weeks, more than 128 solution, it is a very predictive for cardiac events later in pregnancy. Now to treatment percutaneous coronary intervention with coronary stent, and thrombolysis should be avoided because of risk of hemorrhage and fetal risk. Now the aortic dissection, the aortic dilatation now the coarctation of aorta aortic dissection Marfan syndrome solution, aortic dilatation machine down 1% chance of aortic dissection. The diagnosis is CT scan, transesophageal echocardiogram. Pregnancy marker, it's not as safe as MRI. Yeah? Depending on the mother's condition, if you have to be done, you have to be done. It's always need to balance the risk of doing investigations and risk of not doing investigations. Yeah. The aortic dissection but the systolic hypertension control of dilatation solution hypertension you should start beta blockers as an antihypertensive, yeah, to prevent dissection. Especially near full term or immediate post delivery regular echo and monitor follow up. Valvular heart disease. Yeah? Valvular heart disease is common. Mitral stenosis it is a very the valvular heart disease with highest risk in pregnancy is mitral stenosis. The pre-pregnancy moderate or severe mitral stenosis and pulmonary stenosis intervention considered severity valve area now the ejection fraction complications pulmonary edema atrial fibrillation. Okay, so atrial fibrillation, mitral stenosis, if it is severe mitral stenosis solution, increase left atrium and left atrium volume များလာတဲ့ခါကျတော့ wall tension increasing ဖြစ်လာမယ် wall tension increase ဖြစ်လာပြီးတော့ stress related activation ပေါ့နော် stress related activation of ion channels တွေကနေပြီးတော့အဲ့မှာ arrhythmias ရမယ်အဲ့တော့ intrapartum management မှာဘာအရေးကြီးလဲဆို fluid management အရေးကြီးတယ် okay so fluid management are very important ဖြစ်တယ်to the the aortic stenosis မှာဆိုလို့ရှိရင်you need to avoid sudden decrease in systemic vascular resistance yeah so အဲ့ဒါဘာအတွက်လဲအရေးကြီးလဲဆို anesthetist တွေအတွက်လဲအရေးကြီးတယ် when they give regional anesthesia ဆိုရင်လေနောက်တစ်ခုကyou need to avoid the fluid overload ဆိုတော့ intravenous fluids တွေကို avoid လုပ်ရမယ် if it is possible solution in compared to stenotic lesions regurgitant lesions the mitral and aortic regurgitations they are normally well tolerated into pregnancy ဖြစ်တယ် Is everything all right? Okay peripartum cardiomyopathy ကတော့ဘာကိုပြောရလဲလို့ဆိုတော့သူကဒီ heart failure without apparent underlying cause ပေါ့နော်towards the end of pregnancy မှာဖြစ်တယ် in particularly ဆိုရင် 1 month pre-delivery to 5 months after delivery မှာဖြစ်တယ်အဲ့တော့သူရဲ့ underlying cause ကသိပြီးတော့ apparent မဖြစ်ဘူးဒါပေမဲ့လည်းပဲ so unexplained persistent dyspnea tachypnea tachycardia ဆိုလို့ရှိရင်ဒါသတိထားရမယ်ပေါ့နော်အဲ့တော့သူရဲ့ differential diagnosis ကတော့ pulmonary embolism ဖြစ်တယ်နောက်တစ်ခု heart failureလည်းပဲ two peaks ပေါ့နော် so as I've shown before the first week is towards the end of the second trimester and the second peak is at peripartum period and early postpartum okay so diagnosisကတော့ by means of the clinical diagnosis chest x-ray echo and laboratory DPNP measurement okay the heart failure can be safely managed during pregnancy yeah so the main medication are beta blockers for no now diuretics to so no very careful administration and also we should avoid ACE inhibitors only after delivery mama postpartum afterload reduction ACE inhibitors to because heart failure refractory heart failure solution or not responding to medication so no delivery is indicated so mechanical heart valves they are all the metallic or mechanical heart valves they are the valve damage some of the rheumatic valvular heart disease mechanical heart valvesအဲ့တော့သူ့ရဲ့ complication ကတော့အဓိကဘာကိုကြောက်တာလဲဆိုတော့ valve thrombosis နဲ့ other thromboembolism so it is a very challenging situation နော် so သူကဘယ်ပေါ်မှာမူတည်လဲလို့ဆိုလို့ရှိရင်ဒီ anticoagulant side effects တွေကြောင့်မလို့ဘာဖြစ်လို့ challenging ဖြစ်လဲဆိုလို့ရှိရင် due to side effects of anticoagulant you need to choose the timing of delivery monitoring and effectiveness yeah so always need to compare the risk of warfarin which is oral anticoagulant on the baby because it is the teratotoxicity versus the effectiveness of low molecular weight heparin yeah so heparin effective there is still 17% risk of venous valve thrombosis despite strict monitoring of anti-10A level yeah so hematologist involvement is very very important yeah you need to discuss with hematologist right so arrhythmias they are the one of the most common complication of cardiac underlying conditions so the commonest type are supraventricular tachycardia the treatment are underlying etiology acute chronic condition hemodynamically stable unstable risk and benefits of medications okay the both anatomical changes to your physiological changes to your underlying cardiac conditions cardiac arrhythmias previous history of arrhythmias ရှိရဆိုလို့ရှိရင်เนาะ recurrence during or 1 month after pregnancy is very common. Yeah. Investigations တွေအနေနဲ့ကတော့ resting or ambulatory ECG, echo and serum electrolytes, yeah, is very important. Electrolyte imbalance တွေမှာလည်းပဲ arrhythmias ရနိုင်တယ်. နောက်ပြီးတော့ thyroid conditions နဲ့ hyperactive thyroidism မှာဆိုလို့ရှိရင်လည်းပဲ arrhythmias ရနိုင်တယ်. အဲ့တော့ဒါကတော့ဟိုပဲပြောချင်တာပါ underlying cause ကတကယ်လို့ organic heart disease ရှိလား non organic heart disease လားဆိုတော့လေအဲ့တော့ non organic heart disease ကသူကဒီဟိုဟာတွေမှာပေါ့ mostly ဒီ congenital တွေဖြစ်တာများတယ်အဲ့တော့ congenital ဖြစ်တယ်ဆိုလို့ရှိရင်congenital condition ဒါပေမဲ့လည်းပဲ it's not diagnosed at the time of delivery and later on it can develop at later stage. Yeah. So for example solution the Wolff Parkinson White syndrome လို့အဲ့ဒါတွေကတော့ဒီ accessory pathway ရှိတဲ့အတွက်ကြောင့်လို့ပေါ့နော်နောက်တစ်ခုကတော့ဒီ ventricular tachycardia ဆိုရင်ဘယ်လိုမျိုးတွေမှာတွေ့နိုင်လဲဆိုရင် Brugada syndrome လို့ long QT syndrome လို့အဲ့ဒါတွေကတော့ဒီ ion channels တွေနဲ့ဆိုင်တယ်နော် sodium နဲ့ potassium channel တွေနဲ့ဆိုင်တယ်Now, the package of underlying structural heart disease ရှိမယ်ဆိုလို့ရှိရင်အဲ့ဒါပါလဲဆို surgically corrected လုပ်ထားတဲ့ congenital heart disease တွေမှာဒါမှမဟုတ်ရင် valvular cardiac disease တွေမှာဖြစ်တယ်အဲ့ဒါတွေကဘာလို့ဖြစ်တာလဲလို့ဆိုတော့သူကဒီ previous operation ရှိရဆိုရင် it is scar related နော် scar related ဖြစ်ပြီးတော့သူက it can lead to the complex and serious hemodynamic consequences yeah ဒီဖြစ်နိုင်တယ်အဲ့တော့ဒါတော့အသေးစိတ်တော့မသွားတော့ပါဘူးအဲ့တော့ဒီ treatment ကိုကြည့်မယ်ဆိုလို့ရှိရင် acute situation မှာဆိုရင်ဘယ်လို treat လုပ်မလဲ prophylactic အနေနဲ့ဘယ်လို treat လုပ်မလဲအဲ့တော့ acute situation မှာဆိုလို့ရှိရင် hemodynamically stable ဖြစ်သလား unstable ဖြစ်သလားအဲ့တော့ stable ဖြစ်တယ်ဆိုရင်တော့ဒီ intravenous adenosine သုံးနိုင်တယ် verapamil သုံးနိုင်တယ် beta blockers တွေသုံးနိုင်တယ် unstable ဖြစ်တယ်ဆိုရင်တော့DC cardioversion, it is safe during pregnancy. Yeah. Prophylacticအနေနဲ့ကတော့ beta blockers တွေအဲ့တော့ beta blockers ကတော့ it is safe during pregnancy ဆိုတော့ everywhere မှာ we use it နိflecainide သုံးနိုင်တယ်ဒါပေမဲ့ catheter ablation ကိုတော့မလုပ်ဘူး during pregnancy မှာ contraindicated ဖြစ်တယ် because of the high radiation exposure ကြောင့်မလို့အဲအကြောင်းမလို့ဒီ prenatal counseling မှာဆိုလို့ရှိရင် so if the patient has arrhythmia due to congenital cardiac conditions, you can offer cardiac catheter ablation therapy before pregnancy, not during pregnancy. Okay. There are drugs related to cardiac conditions and its effects on pregnancy and fetus. Okay. So beta blockers, they are, it is known to be safe during pregnancy. You need to monitor the signs of growth restriction of the baby and neonatal hypoglycemia. Yeah. Now to call beta mimetics ne acetopin. The beta mimetics are a solution. You know, I don't know preterm labor, tocolytics and in it don't get it. Aortic tachycardia, arrhythmias, atosipan are safe. Low molecular weight heparin are no harmful effects. Are less effective compared to oral anticoagulants. Yeah. Antiplatelets are especially antiplatelets solution the aspirin cyclopidol. No, when you are considering regional anesthesia solution, you need to be careful how much antiplatelets she's taken it. Now to cook pulmonary arterial vasodilator, so there are no reports of human toxicity. Now prostaglandins, so yeah, prostaglandin F carboprosca pulmonary edema pinine. There is a risk of pulmonary edema. Only used second line and in Now to prostaglandin E2RO, there is no harmful effect. Yeah, there are propest to prostin. Now, high dose misoprostol so in coronary vasospasm arrhythmia ya naine. So the postpartum hemorrhage so in low dose of misoprostol with on. Now to glycerine trinitrates cancellation, risk of postpartum hemorrhage pinane. Now diuretics it is actually contraindicated during pregnancy or use it with very limited circumstances. And ACE inhibitors, they are contraindicated during pregnancy because of the risk of renal agenesis. And warfarin, warfarin, if you use it in the first trimester, so in embryopathy, yeah, teratogenicity, if you use it in the later part of the gestation, so in there is risk of fetal loss and hemorrhage. Okay? Oxytocin, it is safe during pregnancy, but need to be careful about systemic hypertension. Okay, so it's nearly there. So the multidisciplinary team are important pillars for no? Teamwork is very important to get the best outcome of baby and mother. So the women are solution the team they are alone contact the team to chin contact no? Discuss liaise cardiologist and cardiac nurse specialist, yeah, and anesthetist, in particular obstetric anesthetist, yeah, a neonatologist, and sometimes geneticist if it is the genetic condition, so yeah, and hematologist if the woman is using anticoagulants, so yeah. So EP team electrophysiotherapist, yeah, about if the woman has a pacemaker or ICD insertion solution reprogramming nivarita. Onto ICU team and high risk obstetric team. Yeah. So they all should be available. They all should be available. Okay. Although it is difficult in some places. So this is the key points. Yeah. Key point are about cardiac disease. The most common indirect cause of maternal mortality. Part of that solution, late diagnosis, yeah? and cardiac disease more potential to remain undiagnosed, especially in the acquired heart conditions. Therefore, it is very important to keep the low threshold for doing investigations such as echo, MRI, CT scan, BNP. Yeah. So someone with dyspnea and tachycardia, which is disproportionately to pregnancy solution, should do the investigation quickly. And severe chest pain requiring opioid analgesia. Yeah. And also new onset of palpitations or sudden worsening of shortness of breath, syncope, near syncope, prompt assessment of arrhythmias is important. Yeah. Now to the important risk factors so in preeclampsia, during pregnancy, assisted reproduction and venous thromboembolism, they can quickly lead to the decompensation. Yeah. Delivery vagina delivery with low dose regional anesthesia and careful fluid management. Yeah, fluid management is very important in cardiac cases. So the main aims of management are early risk assessment, optimization, planning of delivery, regular monitoring for deterioration, especially in the immediate postpartum. Yeah, and specialist input MDT involvement are very, very vitally important. You cannot manage on your own, and you need help from other people. Yeah. So these are the references. And thank you very much for listening. Okay. And okay. Is there any question?
Okay, ma. Question me tali shiပါတယ် ma.
Okay. Question 6 ခုကျွန်တော်ရှာလာတယ်ပေါ့နော်။ ကျွန်တော်ဘယ်နောက်ဆုံးအပေါ်ဆုံးကနေစမိတဲ့ဟာနေကျွန်တော်စလိုက်မယ်เนาะအဲ့မှာတယောက်ကသူမှားပြီးတော့ကျွန်တော်စီကို direct message နဲ့ဝင်နေတယ်ဒါပေမဲ့အဲ့မှာတခုဗာမေးတာလဲဆိုတော့ what is the feature of hot oram and NOOAN ဟိုက congenital heart disease ကျွန်တော်တော့အခုစမကြားဘူးအဲ့လိုပေါ့เนาะခောက်ပြန်ခောက်ချကြည့်ရတယ်အဲ့တော့အဲ့ဒါလေးကိုသူတစ်ချက်ပြောခိုင်းနေတယ်အမ hot oram နဲ့ no and တဲ့ဟာကိုပြောခိုင်းတယ်
ပြောပေးမယ်အဲ့ဒါဘာလဲလို့ဆိုတော့ so it is a genetic condition it is a genetic condition and is characterized by skeletal abnormalities of hands and arms upper limbs together with heart problems yeah အဲ့တော့ heart problems မှာဆိုရင်ဘာတွေပါလဲဆိုရင်cardiac conduction disease တွေကိုပြောတာနော်ဒီ cardiac conduction disease တွေလည်းဖြစ်နိုင်တယ်ဆိုလို့ကျွန်တော်တို့ arrhythmias ပေါ့နော် arrhythmias ရှိနိုင်တယ်ဒါမှမဟုတ်လို့ရှိရင် other heart defects တွေ ASD atrial septal defects တို့ ventricular septal defects တို့ရှိနိုင်တယ်အဲ့တော့ဒီ genetic conditions အဓိကဘာလဲဆိုတော့ skeletal abnormalities of upper limbs တွေနဲ့ဒီ heart condition မှာ in particular cardiac conduction disease နဲ့or structural heart disease ASD VSD အဲ့ဒါတွေနဲ့အဲ့နှစ်ခုပေါင်းထားတဲ့ဥစ္စာကိုခေါ်တာအဲ့တော့ तू ကဘာလဲလို့ဆိုရင် तू ကautosomal dominant လေ autosomal dominant ဆိုတာဘာကိုပြောရလဲလို့ဆိုတော့ဒီ gene မှာဆိုလို့ရှိရင်two pairs ရှိရမလား two pairs of gene in every DNA လေအဲ့တော့ one is from mother and one is from father so one of those pairs are affected ဖြစ်တဲ့ solution သူက features တွေကိုပြတယ်အဲ့တော့အဲ့ဒါကဘာလဲလို့ဆိုလို့ရှိရင် autosomal dominant so gene ဒီနှစ်ခုစလုံး two pairs စလုံး affected mutation ဖြစ်ဖို့အတွက်ဒီ variation ဖြစ်စရာမလိုဘူး only one of them မှာပဲvariation ရှိတယ်ဆိုလို့ရှိရင်သူကဒီ clinical features တွေကိုပြတယ်အဲ့တော့ mother မှာဒီလိုမျိုး condition ရှိတယ် autosomal dominant condition ရှိတယ်ဆိုရင်there is 50% risk of her pregnancy is affecting the same condition ရှင်းလားမသိ
ဟုတ်ကဲ့ပါကျေးဇူးတင်ပါတယ်
ဟုတ်ကဲ့
နောက်တစ်ခုသွားလိုက်မယ်เนาะကျွန်တော်နောက် question ကကြတော့အခုကတော့ဖြည်းဖြည်းချင်းများဆက်ပြီးမေးလာတယ်အဲ့တော့အခုဆိုကျွန်တော် so far 6ခုရပြီနောက်တစ်ခုကတော့ normal ECG နဲ့တဲ့ can normal ECG exclude cardiac disease in pregnancy တဲ့
normal ECG can exclude cardiac disease in pregnancy ဟောပေါ့နော် cardiac disease ဆိုတာကဘာပြောရလဲဆိုတော့ structural heart disease ရှိတယ်နော် structural heart disease ရှိမယ်နောက်တစ်ခုကဒီ functional ပေါ့နော်ဒီ structural ဆိုတာကတော့ဒီ structure ပဲ wrong ဖြစ်တာလေနော် structurally wrong ဖြစ်တယ်ဥပမာပြောမယ်ဆိုလို့ရှိရင် ventricular septal defect တို့ atrial septal defect တို့နော်နောက်တစ်ခုက mitral stenosis တို့ aortic stenosis တို့နော်ပို့ပြီးတော့ complicated terms တွေကိုသွားမယ်ဆိုရင် tetralogy of Fallot တို့အဲ့လိုမျိုးသူ့ရဲ့ heart structure ကမှားနေတာနော်နောက်တစ်ခုကတော့ functional problem ကတော့ဒီ electricity ပေါ့နော်ဒီ heart rate နဲ့ပတ်သက်ပြီးတော့ heart rate ကvery slow ဖြစ်ရင်ဖြစ်မယ် very fast ဖြစ်ရင်ဖြစ်မယ် tachycardia ဖြစ်မယ်ဒါမှမဟုတ်ရင် irregular ဖြစ်ရင်ဖြစ်မယ်နော်ဒါကတော့ arrhythmia နဲ့ဆိုင်တဲ့ဟာတွေပေါ့အဲ့ဒီတော့ဒီ ECG ကတော့အဓိကကတော့ functional heart disease တွေကိုdetect လုပ်ဖို့လို့အတွက်ပေါ့နော်အဲ့တော့ဒီရိုးရိုးသားသားပဲဒီ structural heart disease ဥပမာ ventricular septal defect ပဲဆိုရင်တော့ I don't think we will see the ECG changes လေနော်အဲ့တော့ normal ECG cannot exclude underlying cardiac condition underlying cardiac structural disease okay
Okay,ကျေးဇူးတင်ပါတယ်ဟုတ်ဒါ second question ပေါ့နော်နောက် question တစ်ခုကတော့သူဘယ်လိုမေးလဲတော့မသိဘူး what is percutaneous therapy သူကြည့်ရတာအမကိုပြောလိုက်တဲ့တည်းမှာလေ intervention မှာအဲ့ဒါက percutaneous intervention နည်းနည်းပြောခိုင်းတယ်ထင်တယ်
percutaneous intervention အဲ့ဒါကတော့ဒီဟိုဟာတွေပေါ့ coronary arterial stent ထဲတာတွေပါတယ်ပေါ့နော်အမပြောချင်တာကတော့ so during pregnancy မှာဆိုလို့ရှိရင် we need to avoid the open heart surgery လေ so open heart surgery ကို avoid လုပ်ရမယ်ဆိုတဲ့အခါကျတော့ less invasive method တွေကိုပဲသုံးတာပေါ့နော်အဲ့တော့ percutaneous therapy ကတော့ဒီ stent procedure တွေပါတယ်ဆိုတော့တိတ်ပြီးတော့ invasive မဖြစ်ဘူးပေါ့အဲ့ဒါကိုပြောချင်တာပါအဲ့ဒီဟိုစားလေ myocardial infarct တို့ပါတော့ ischemic heart disease တို့ပါတော့မှလုပ်တယ်နောက်တစ်ခုကဒီ mitral stenosis aortic stenosis မှာလည်းပဲလုပ်တယ်
ဟုတ်ကဲ့ပါကျေးဇူးတင်ပါတယ်ဟိုဟာနောက် question က which cardiac disease are necessary for safe termination of pregnancy ကျတော့သူ absolute indication ကိုပြောတယ်ထင်တယ်
yeah so အဲ့ဒါကအမပြမယ်ဥစားကိုတွေ့ရသေးလားမသိဘူးเนาะအမရဲ့ slides တွေကိုတွေ့ရသေးလား
ဟုတ်တွေ့ရပါတယ်ကျွန်တော်ဘက်က
တွေ့ရတယ်เนาะအဲ့ဒါကဒီမှာလေ
အမအဲ့တနေရာမှာ mention လုပ်သွားတယ်เนาะ
mention ဒီမှာကြည့်လိုက်
ဟုတ်ကဲ့ဒါ
เนาะ so factor associated with high maternal risk အဲ့ဒါအဓိကဒီဟိုပါပေါ့ congenital heart defects တွေမှာဆိုလို့ရှိရင် severe symptomatic aortic or mitral valve stenosis yeah and pulmonary arterial hypertension and any heart condition when there is systemic ventricular ejection fraction less than 30% yeah and poor functional class so New York Heart Association assessment of heart failure if it is class 3 and 4 solution should not get pregnant now to call aortic diameters aortic diameters more than 45 millimeter in which conditions so maybe in Marfan syndrome maybe in bicuspid aortic valve maybe in aortic aneurysm yeah and another condition severe coarctation of aorta and arrhythmia any previous arrhythmias arrhythmias means atrial fibrillation atrial flutter ventricular tachycardia ventricular fibrillation yeah and any previous cardiac event means a history of heart failure history of stroke history of TIA transient ischemic attack or history of yeah so these are the cardiac events no debate on the left side for very high maternal risk so these patients can result in catastrophic complications if they get pregnant no therefore they should be discouraged to get pregnant okay
ဟုတ်ကဲ့ပါကျေးဇူးတင်ပါတယ်နောက်တစ်ခုကနောက် question ကကြတော့ what is the mode of delivery and treatment on regurgitation of mitral or aortic valve
so mitral or aortic regurgitation it is less risky yeah compared to mitral or aortic stenosis because when you look at the physiological changes of pregnancy, there is a reduce in peripheral resistance. Now, peripheral vascular resistance are near reduce low period. To compensate for the increasing stroke volume, the plasma volume. Regurgitant lesions, the regurgitant to the blood flow compensate low pain. So peripheral resistance are near it. No, if it is not severe aortic or mitral regurgitation solution, vagina delivery is the mode of delivery. Okay. So Cesarean section underlying cardiac disease resolution. Cesarean section it is only for the obstetric indication. There are only very few cases that need the elective Cesarean section. Okay. Yeah, Cesarean section only for the obstetric indications such as a breech presentation, 2 previous Cesarean section, yeah, or transverse line. So obstetric indications at Cesarean section load there. They are only very few conditions that is indicated for cesarean section, such as pulmonary hypertension. Yeah. Solugena balelusro, severe aortic stenosis. Yeah. Severe aortic stenosis leading to pulmonary hypertension. No? Aortic dilatation more than 45 millimeter, or severe heart failure, or pregnant women on oral anticoagulants if they go into preterm labor. So these are only the absolute indication for cesarean section. Other cardiac conditions should have the vagina delivery. So Solugena vagina delivery with adequate pain relief is the preferred method of delivery, but you might need to shorten the second stage of labor. No, it is not the correct choice of word. So you might need to give the assisted operative delivery for, sorry, you might use the instrumental delivery, yeah, in order to avoid the pushing during second stage. Pushing contractions to do it, you know. So peak of contraction, peak of pushing sudden increase in further increase in stroke volume, plasma volume cardiac decomposition. Okay, there are summary in there. Yes, regurgitation it is not the indication for cesarean section. Vaginal delivery can be allowed with adequate pain relief. Okay.
ဟုတ်ကဲ့အမကျေးဇူးတင်ပါတယ်အမအခုပြောလိုက်တဲ့တဲမှာဆိုအခုကျွန်တော်နောက်မေးမယ့် question ပါတခါတည်းပါသွားပြီတင်တယ် How do you determine a pregnant woman with congenital heart disease is safe to deliver vaginally ဆိုခုနအမပြောတဲ့တဲမှာတခါတည်းပါသွားပြီလို့ထင်ပါတယ်နော်
သင်ပါသွားပြီ
အဲ့ဒါဆိုကျွန်တော်ကြော်လိုက်မယ်နောက် question ကိုသွားလိုက်မယ်how to manage a patient with ischemic heart disease that cause drugs used during delivery can precipitate MI
myocardial infarct. Can you repeat the question?
How to manage the patient with ischemic heart disease? Cause drugs used during delivery can precipitate MI.
During delivery, myocardial ischemic acute coronary
heart disease ရှိတဲ့ patient တယောက်မှာအမသူအဲ့လိုမျိုးသုံးလိုက်မဲ့ စီးတွေက MI ကို precipitate ဖြစ်စေတဲ့အတွက်ကြောင့်ဘယ်လို manage လုပ်ရမလဲတဲ့
အဲ့တော့အဓိကကတော့ဒီ underlying cardiac disease ရှိတဲ့ solution some medications are absolutely contraindicated လေargametrin solution ရှောင်ရမှာပေါ့နော် you must never use argametrin or symptometrin in patients with underlying cardiac condition. So number one, it can cause hypertension. Number two, it can cause coronary spasm and ischemia. No, highly suspicious of acute coronary syndrome in labor solution. Glycerine trinitrates too. No, glycerine trinitrates to the medical treatment ကိုရင်ဆုံးသွားရမယ်။သွားပြီးတဲ့အခါကျတော့အဓိကတော့ဟိုပါပေါ့ MDT management အရေးကြီးတယ်ဆိုတာကိုပြောတာနော်။အဲ့တော့you need to be involved by obstetric anesthetist and then the ICU team. Yeah. So if it is not responding to the medical treatment solution တော့ဒီခုနကတော့ပြောတဲ့ percutaneous coronary stent တို့ပါတော့အဲ့လိုမျိုးတွေပါလာတာပေါ့နော်။ thrombolysis ကတော့တချို့ case တွေမှာ after delivery solution သုံးပါတယ်ဒါပေမဲ့ during pregnancy solution တော့မသုံးဘူး
ဟုတ်ကဲ့အမကျေးဇူးတင်ပါတယ်နောက်တစ်ခုကquestion ကြီးကတော့၄ခုလောက်ကြံသေးတယ်အမဟိုကျွန်တော်တို့ကတော့ဒီ session ပေါ့နော်နောက်9မိနစ်လောက်ကြာရင်ဟိုရက်လိုက်မယ်လို့ plan လုပ်တော့ဆိုတော့နည်းနည်းလေးပြန်ပြီးသွားလိုက်မယ်နော်
ရတယ်
if a woman is taking warfarin for AF and has not recognized having pregnancy, how can warfarin affect on pregnancy? အမပြောထားတဲ့ဟာမှာပါပါ
အဲ့တော့ warfarin ကဘာဖြစ်လဲလို့ဆိုတော့ warfarin ကသူကဒီ first trimester မှာသုံးမယ်ဆိုလို့ရှိရင် very teratogenic လေ no teratogenic embryopathy abnormalities fetal abnormalities တွေဖြစ်နိုင်တယ်ပေါ့နော်အဲ့တော့ first trimester မှာမသုံးမှုပေါ့နော်နောက်တစ်ခါကျတော့ third trimester မှာကျတော့သူရဲ့ complication ကဘာလဲလို့ဆိုတော့hemorrhage နော်ဒီ fetal hemorrhage ပေါ့ intracranial hemorrhage တို့ဘာလို့ဖြစ်နိုင်တယ်အဲ့တော့ fetal loss လည်းဖြစ်နိုင်တယ်ဆိုတဲ့အခါကျတော့အဲ့တော့there are the numerous ways for using anticoagulants during pregnancy. So some obstetrician use low molecular weight heparin throughout the pregnancy to avoid those risks. Now, less effective the two physicians, the two obstetricians, they are the warfarin or anticoagulants go. Risk and benefit ratio warfarin, yes, there is a risk, but what is the level of the risk? It is less than 7% risk, yeah, of using warfarin solution. There is 7% risk of causing embryopathy and 7% risk of causing fetal hemorrhage and loss and etc. so on. But on the other hand, there is 17% of risk of valve thrombosis by using low molecular weight heparin. Balance low below the level, it doesn't matter. Even if there is the embryopathy, we will use it because the risk is small. Yeah, the two obstetrician level. First trimester ma warfarin, first trimester ma heparin tone. Second trimester jaro the kapian biro warfarin piang like that. Third trimester jalo shin the kapian biro heparin pian biro tone low molecular weight heparin pian biro.အဲ့လိုသုံးတဲ့အခါကျတော့နည်းနည်းတော့ chaotic ဖြစ်တာပေါ့နော်ဒီလို monitor လောက်ရတာတွေကခက်လာတာပေါ့ဘာလို့လဲလို့ဆိုတော့ဒီ anti-10A နဲ့ဒီ heparin ကို monitor လောက်ရတာတော်တော်လေးကို tricky ဖြစ်တယ်အဲ့တော့ warfarin ကိုသုံးလို့ရပါတယ်တကယ်လို့ low dose နဲ့သုံးမယ် INR level က less than INR level ဒီ INR level ကို low dose နဲ့ maintain လုပ်နိုင်တယ်ဆိုလို့ရှိရင်yes, you can use the warfarin throughout the pregnancy. Okay.
Okay, ma, Jesus, the man. Now, another question. Element, the science about question and the knowledge. How to change medication in pregnant women with AF with valvular or non-valvular? Non-valvular or non-valvular, medication choice. How to change medications? I don't think normally.
We're pure on it today. That
choice of anticoagulation will be right
in choice of anticoagulants. The Amaruaro third trimester Yaubi solution. Wow, low molecular weight heparin you need to be strictly monitored anti-10A level. Yeah, so anti-10A level at desired level PM. In order to prevent valve thrombosis and thromboembolism. Okay. Valvular and non-valvular.
Valvular and AF pregnant woman with AF valvular AF and non-valvular AF.
Treatment are the same. Valvular so solo atrial fibrillation solution. Non-valvular or you couldn't count your the syndrome, long QT syndrome, Regurgitation syndrome, any osaria level, chinine. No, this syndrome they are level, the timely treatment solution through a very it can lead to the catastrophic conditions, really. No? Okay.
Question now how to manage some women with rheumatic valvular heart disease with pulmonary hypertension? The prostaglandin analogs are given, but prostaglandin can cause uterine contraction too. How to manage at that time, please?
Okay, so if there is pulmonary hypertension, pregnancy should be discouraged. Okay. And then, but if she get pregnant, there is it is very, very high risk. Someone with pulmonary hypertension should not get pregnant. And if it is pregnant, it is very, very high risk. and delivery is by elective cesarean section as early as possible. Okay, so I shouldn't wait until 10 pregnancy. So it should be delivered by early third trimester or something like that.
Okay, ma. This is my now some question. In pregnant women with heart failure, taking ACE inhibitor, does it need to change other drugs if possible? Proven survival drug,
Yeah. So ACE inhibitors are contraindicated during pregnancy. We don't give it. So I mean, mainly is we use beta blockers. Yeah, beta blockers and what else? Yeah, but if it is refractory to the treatment solution or delivery load, yeah, beta blockers they don't have inotropes they don't have. But diuretics are you need to be very careful. No, very low dose may be used. Okay, so as soon as the baby is at the stage of survival, we deliver.
Okay, ma. This is the money. No question in Talara.
Okay.
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 As general Q&A session,
Okay. So I'm sorry, it might be too much for part 2, but yeah, sorry about that. And all the best wishes. Okay. And Pamabi agent Dayawasi. Okay, bye-bye.
Bye ma, Jesus ba.
Okay. Oh.